Dr. Rashid?
Yes, it's on now.
There we go. Hi, Dr. Felix.
Yeah, can you see me?
Yes, thank you.
Perfect.
Okay.
All right,
Good.
excellent. So everyone's cameras are working. Can we do a quick microphone test? Dr. Mulia, can you unmute yourself real quick so we can do a quick test? Dr. Mulia, can you unmute yourself?
Hello?
All right.
Yes?
All right, perfect. We hear you loud and clear.
Perfect.
All right. Mike?
Okay.
I think, Lauren, when is there an echo on your side? Or is,
I think it's because I was not muted, but I'll just go through each one real quick and then mute myself. Mike, can you do a quick test of your audio?
Okay.
Excellent. Rashid?
Okay, I'm here. I don't know if you hear me.
Perfect.
It's okay?
Thank you.
Okay, good.
Dr. Felix?
Yes, greetings everyone. Can you hear me?
Loud and clear.
Right. Thank you.
All right. So the only person we're missing at this point is Tandaway. So hopefully she joins. But again, she is the final presenter. And if she is unable to connect, Nigeria will be our last presentation and we will just go into the Q&A. But again, hopefully she'll be able to connect.
sounds good. I think we are ready when you are.
All right. So we can start. Megan, should I go ahead?
Of
Yes,
course.
yes, please. And Monica, you'll be going through the slides, right? Flipping through. Yeah, let's begin. Thank you.
All right, excellent. Good morning and good afternoon, everyone. Welcome to the local partner session on client-centered services, focusing on multi-month dispensing and decentralized drug distribution. My name is Lauren Bailey, and I'm the MMD advisor at USAID Washington, and I will be moderating today's session. Just a quick reminder, if you are not speaking, please keep yourself on mute. So we have a packed agenda today, which includes presentations from partners in Haiti, the Democratic Republic of the Congo, Malawi, Nigeria, and Zambia. We will go through each presentation, and then I will turn the microphone over to my colleague, Hannah Marcuzzi, to facilitate a Q&A and a brief discussion on key takeaways from today's conversation. We are incredibly excited to host this session on client-centered services, which features the work of 5 partners who each implemented innovative approaches to scaling up MMD and DDD in their countries. USAID's implementing partners, particularly our local partners, are leading the charge across the PEPFAR program to increase the provision of MMD and DDD services. While MMD and DDD are not necessarily new to PEPFAR-supported countries, we have seen a tremendous increase in MMD coverage and DDD in the last 6 months during the COVID-19 response, as MMD and DDD became key solutions to decongesting health facilities and promoting uninterrupted access to ARVs to the nearly 4 million USAID-supported PLHIV on treatment. As we move into COP21 planning, it is critical that we capitalize on the gains made to advance decentralized, patient-centered clinical service delivery. And we hope that today's session helps underscore not only the innovations being implemented to scale up services such as 6-month ART dispensing and mobile ART delivery, but also demonstrates the profound benefits of MMD and DDD on the patient and healthcare system. And now I'd like to introduce our first presenter. Dr. Rashid Dorsonville from Fondation Serovi in Haiti will be presenting on 6-MMD uptake among key populations using community drug distribution in Haiti. Over to you, Dr. Dorsonville.
Thank you, Lauren. Good morning, everyone. My name is Rashid Dorsonville. I'm a medical doctor, and I'm care and support advisor at Fondation Serovi for the Epidemic Control Among Priority Population Program, commonly known as ECP2. So ECP2 is a local cooperation agreement aimed at controlling and containing the HIV epidemic among priority population in Haiti and is managed by the largest local organization in Haiti in collaboration with the Ministry of Health and 2 other local partners. But today, I will have to present an abstract about a strategy that Fondation Serovi have been using to increase the 6-month, multi-month dispensing uptake among key population in Haiti. And the abstract title is Increasing 6-month, multi-month dispensing among key populations using community drug distribution in Haiti. Next, please. In January 2019, Fondation Serovi started with the implementation of the 6-month MMD, also as it was recommended by the Ministry of Health. Then the strategy came among others to help our network to improve patient retention. First, by decreasing clinical review visits, and second, by reducing congestion and waiting time in the clinics. However, it was very challenging to implement this strategy among key population because many of them refused to be provisioned with 6 months of drug, as it was very difficult for them to manage this huge stock of drug at home. Then as a result, during our first quarter of implementation, particularly in Q2 for year 19, the uptake of MMD was very low, around only 37%. Then we were thinking on how we would increase the uptake of MMD, so that we decided in April 2019 to involve peer navigators to help patients in the management of their 6-month MMD supply by using the community drug distribution, and therefore see what the result would be. Next, please. So how did we involve peers to increase MMD? In fact, the community drug distribution is being used within Serovi network since 2017, and it has helped improve patient retention. And through CDD, the community drug distribution, patients can normally get their medication from the peer navigators who deliver this medication to them in the community on time, on date, and place that they have indicated. And given the challenges we were experiencing where patients were complaining about the difficult management or the huge stock of drugs at home, we decided to use the community drug distribution to increase the number of patients on 6-month MMD. Then what was the strategy? So once a patient become eligible for MMD and registered as receiving 6 months of MMD at the clinic, the drug dispenser offers the patient the option to give him half of his six month drug stock and save the other half at the clinic in a drug dispenser box. And on a 2 or 3 month basis, according to the patient preference, the peer navigator will deliver after the other half in the community to the patient, as I mentioned above, in the date, time, and place that the patient have indicated. Then what we observe after the introducing this strategy. So next slide, please. Okay, now the results. So what we observed from March 2019 to August 2020, the uptake of MMD has increased significantly, and it went from 37 in March 2019 to 85% in August 2020. And as you can see in the graph, among all of our takes current, 85% were receiving a drug for 6 months, and followed by 14% that were receiving 3 to 5 months MMD, and only 1% with less than 3 months of medication dispensing. So in conclusion, we can say that the switch to 6 months MMD was very challenging at the beginning of the, next slide, please. Okay, so in conclusion, we can say that the switch to 6 months MMD was very challenging at the beginning of its implementation. So as I mentioned above, patients eligible for 6 months MMD or more were elected to receive their stock, but introducing peer support to the community drug distribution has proven to be very, very effective in improving this strategy. And what we're going to do in Fondation COV, so we will continue to implement this strategy and also to ensure that all eligible patients can effectively receive the MMD as recommended by the Ministry of Health. So thank you.
Thank you, Dr. Dorsonville. Our next presenter is Dr. Muya Kanyinda from Ketempilo in DRC, who will be presenting on the scale-up of pediatric MMD in Lualaba province in the Democratic Republic of the Congo. Dr. Muya, over to you.
Good morning, everybody. Good afternoon. I'm Dr. Muya. I'm presenting on behalf of Ketempilo, DRC. I'm a DCOP for Ketempilo. I'm presenting on the scale-up of pediatric MMD in Lualaba province in DRC. Next slide, please. So Lualaba province is one of the copper and cobalt mining hub, which is situated in the southwestern of DRC, and it has the border with Zambia and Angola. We have a population of about 2,204,000, and it is covered by a lot of artisanal mining areas with a very mobile population. The Ketempilo project is implementing a HIV epidemic control project for USAID, and we are covering 53 sites out of 74 for the 14 F zones, but we are covering first 10 F zones for the FY20. In FY21, we are going to cover all the 14 F zones. By the Q3 of F20, we had about 15,572 patients on ART, and our approach is based on the case finding, index testing, TX new retention, and follow-up of the results every time. Now, with the event of COVID-19, as we know, all of us, there have been restrictions on social gathering and the reduced facility visits in most of the sites. So this gave us the necessity to diversify the provision of all HIV/AIDS clients to give them an efficient differentiated ARV delivery model to children and as well as to the adults. Now, our national program, the PNLS, issued a policy in collaboration with USAID mission of DRC to extend the use of MMD to pediatric clients. And this gave us a chance to start by sensitizing first our Ketempilo staff and our government staff on the use of MMD. Next slide, please. Next slide, please. The methodology we used was a descriptive analysis of our cohort to find the eligible clients who were aged less than 15 years. And we use the clinical record, registers, and TNET, and we had some selection criteria for us to choose those eligible children. So the first criteria was to see all the stable children and adolescents on ART for more than 15 years, those who are more than 3 months on ART, and those who did not have medical or social complications, and those were adhering very well to treatment. And the other criteria was to have a reliable caregiver. And this was a very important criteria because to ensure that the caregiver take care of the child as she's taking medication. We used 2 models. One of the models was facility-based support group of teens. These are a group of children were attached to one of our biggest hospitals in Kolwezi, HPK. And the next group was the individualized direct service delivery, where children will collect directly their medication to the facility. Next slide. As a result, by October 2019, we had a cohort of children, about 952 children on HEART, and only 20% of children were on MMD. So after getting that policy from the ministry and after sensitization, we had all eligible children who were coming for treatment to increase their supplies. And we had to use also phone calls to call others to come for their supplies. And those who were missing their appointment were followed in the community by the nurse and the PA educators. As you can see now on the graph, in October 2019, we had 20% only on ART. By July 2020, we moved to 90%. So we passed from children were 187 to 1,215 children on MMD out of 1,352. This has proved a big shift with the MMD supply to children. Next slide, please. In conclusion, social restriction resulting from the COVID-19 pandemic provided an opportunity to implement the differentiated model of ART delivery for pediatric population. And you can see in our province, we had a steady growth to enroll children from 20%, which was in 2019, to 90% in July 2020. And comparing the 2 groups which we had, the individualized direct service delivery proven that there was a growth of more than 650% compared to the support group at HPK, because there we had just 54 children, but there was an increase to 97, which was the growth of 72%. Next. Thank you very much. We appreciate our funders, PEFA USAID, and especially the USAID mission in DRC. And we appreciate also our Ketimpilo staff team as we are working together with them, and especially the community for DRC. Thank you so much.
Thank you, Dr. Muya. Next, we have Mr. Mike Nyirende from Partners in Hope Malawi discussing Malawi's successful national scale-up of multi-month ART dispensing. Over to you, Mike.
Okay, thank you so much. Good morning and good afternoon to everyone. I'm Mike Nyirende. I'm presenting on behalf of Partners in Hope. I'm currently working with Partners in Hope as a senior program manager. So I'll be presenting Partners in Hope contribution to the successful national scale-up of multi-month ART dispensing in Malawi. Next slide. Firstly, who are we as Partners in Hope? So Partners in Hope is one of the local registered NGOs in Malawi. So at Partners in Hope, we do have a medical facility that offer high quality medical services. And in addition to that, within the Partners in Hope Medical Center, we also do have a molecular lab. So basically, we're able to conduct viral load and EID testing. And our overall contribution to the national testing volume in regards to viral load, we are at 17%. And for EID, we are at 14%. Furthermore, as Partners in Hope, we are one of the longest USAID implementing partner. We started getting funding from USAID a few years ago. At the moment, we are implementing a program called Optimizing HIV Services for Epidemic Control. This is a 2-year project, basically supposed to come to an end next year, 2021, September. At the moment, we are currently implementing our activities in 8 districts, and in total, we are covering 101 facilities across Malawi, as you can see on that slide. Next slide. Okay, so why are we here discussing about 6 months dispensing? We all do need to understand the importance of 6 MMD in regards to HIV care. We do acknowledge the increase in number of growing cohorts in regards to patients who have been put on ART. And it will be important for us to implement differentiated services models that will help to decongest our busy ART clinics. At the same time, we also need to implement models that will definitely save time for our patients who require more intensive and individualized kind of care. At the same time, it's time that we also need to implement DST models such as 6MMD to improve patient satisfaction, and at the same time, trying to reduce disengagement from care. However, from our Malawi experience, before the implementation of our 6MMD, we had some local concerns about the feasibility and the potential for reduced retention. So what did we do as Partners in Hope to address some of the concerns that were raised? Next slide, please. So as Partners in Hope, we did undertook a cluster randomized trial. So basically we compared 3 arms. The first one of the 6 months month dispensing versus the standard of care, and the 3 months MAD dispensing. We also need to take note that we did implement this cluster randomized trial in 2 countries, Malawi and Zambia. And for the sake of this presentation, we are going to focus on the Malawi experience. So in Malawi, PH started implementing this cluster randomized trial that was in April 2019 in 3 high burden facilities as part of the national pilot. Then it was followed by a scheduled rollout to all clinics in January 2020. However, we also need to take note that at the start of the COVID-19 epidemic, the strict 6MMD enrollment criteria was relaxed to facilitate rapid scale up of 6MMD. Next slide, please. Okay, so let's look at what we did find from our cluster randomized trial. So what we saw was that retention, if you look at in the 6MMD arm, was basically non-inferior and compared favorably to the standard of care and the 3MMD. So what we saw was increased retention of 3.5 and 3% respectively. We also went on further to do a cost analysis, and what we noted that there was modest cost saving was observed in the 6MMD arm compared to the standard of care and the 3MMD. We also did conduct in-depth interviews with the clients and the healthcare workers. And what we saw was that 6MMD was appreciated by both clients and healthcare workers. However, we also have to acknowledge that during the implementation process, we also identified some practical challenges. One, we noted that there was a challenge in trying to align the viral load monitoring At the same time, the TB preventive therapy with the 6 MMD. We also realized to say, as a country, we had lack of dedicated monitoring tools to monitor the implementation as well. We also did experience delays of ART optimization and total gravel transition. However, with the coming of COVID-19, some measures that were put to combat the COVID-19 gave a strong impetus to MMD. At the if you look at our data results from PH-supported facilities, we realize to say coverage of 6 months MMD has increased from 13%, that was in Q2, to 36% as of Q3. Similarly, if you look at the coverage of 3 to 5 months, it has also increased from 48% as of Q2 to 54% as of Q3. Next slide, please. Yeah, so this slide just demonstrates the progress that we have made over time. As you can see, looking at the less than 3 months MMD, the 3 to 5 months MMD, and the 6+ months MMD. As you can see, as of Q2, for the 6+ MMD, we are at 13%, but come Q3, we are 36%. Similarly to the 3 to 5 months MMD, we're at 48%, but now we have moved to 54%. Next slide. However, much as we do appreciate the importance of 6 MMD and other MMD models, we also need to understand the practical solutions to align with MMD and the routine valve monitoring. As you can see on this slide, basically we are trying to align the months on ART together with the visit intervals so that our patients who have been enrolled in the multi-month dispensing models, they should be able to have their valve taken at the required intervals, as you can see on this slide. Next slide. So, in conclusion, based on what we found, it's clear that the Malawi HIV program adopted the 6 MMD as an evidence-based strategy to decongest ART clinics. This was this followed up implementation research that PIH conducted, and this has contributed to the national policy. Rapid scale-up of 6 MMD occurred during the COVID-19 epidemic, and also need to understand that there are some practical solutions that were found to help the implementation challenges. Next slide. Okay, thank you so much. Thanks.
Thank you, Mike. Our next presenter is Dr. Felix Iwella from the Association for Reproductive Family Health in Nigeria. Dr. Felix will be sharing how USAID sustained access to HIV treatment in Lagos State, Nigeria during COVID-19 total lockdown through mobile ART delivery, MART-D model. All right, over to you, Dr. Felix.
Good afternoon, good morning, everyone. As introduced, we are implementing a program in Lagos State that for reproductive and family health is supported by USAID in Lagos State, known as the Integrated Child Health and Social Services Award. We are implementing in partnership and Project Hope, which is 10 local government areas in Lagos State. The overarching goal of this intervention is to mitigate the impact of HIV and AIDS on orphans and vulnerable in Lagos State through a multi-sectoral approach. And in addition, we do social development as the coordinator. Hello, can you hear me? Hello?
Hi, Dr. Felix. We're having some difficulty hearing you, but please do continue, and I will let you know if you cut out.
Okay, can you hear me now?
Yes, we can. Thank you.
All right. So as I was saying, it's a 5-year project being implemented by a consortium of 3 partners, Association for the Program of Community Health as a prime, and then in partnership with FHR 360, our treatment partner, and then the Project Hope, responsible for system strengthening both at the community, local government, and state level. We are implementing this intervention in 10 local government areas. In Lagos State, across 52 facilities.
Dr. Felix, unfortunately, we're not able to hear you.
In these 10 local government areas.
Dr. Felix, I apologize. We're having a very difficult time hearing you. You keep cutting out. So I might recommend that we advance to the final presentation and then come back to you, and hopefully some of these issues will be resolved. So could we please advance to the final presentation, and then we will come back? Thank you. So Dr. Tendaway, you are on deck, and I apologize, Dr. Felix. We will get back to you, and hopefully the sound issue will be resolved. So I would like to introduce our next presentation from Ms. Tendaway Malambo of the EQUIP project in Zambia. Ms. Tendaway will be discussing the utilization of the central dispensing unit in Iwella, Copperbelt province in Zambia. Over to you, Tendaway.
Thank you, Lauren. Thank you very much. I hope you can hear me, all of you. So basically, as introduced, I'll be introducing what we call the utilization of the centralized dispensing unit in Zambia. Basically, this is an innovation by EQUIP that is being implemented in one of the districts in Zambia, and it's helping patients actually collect their drugs from different pickup points around town to try and decongest. So going to the background, to give a background on why we have the CDU being implemented. So basically, it was because of the adoption of the test and treat strategy by MOH that increased the number of people living with HIV accessing treatment in the facilities. With this adoption of this strategy, we actually saw an increase of the number of infected individuals on ART actually accessing care. With this, posed a lot of challenges to the health systems as well as the patients. Because of this, can you hear me?
Yes, loud and clear.
Okay, thank you very much. So because of this, then we had challenges of patients because they had to travel long distances to actually go to the facilities. With that also came about some transportation costs. Then, of course, more importantly, we had long queuing times for the patients, and then the cost of medication, as well as competing work and life demands. Together with this, we had the stigma that came into play as well. But also at health facility level, there was an increased demand for commodities. With this increased demand of commodities, there was space constraints in the facilities. We do not have enough storage to store our commodities in the facilities. But then also an increased workload on our healthcare staff. So with this background, then EQUIP came up with an innovation for the central dispensing unit. Next slide, please. Next slide. So going to the objectives of the CDU, basically it was to decongest the high volume sites. We wanted to find a way of getting the patients away from the facilities and still be able to access care from different places within the district. Also, we wanted to reduce the workload at the treatment facility for our health workers. But then, even more important, we had to facilitate progress towards the achievement of the second and third 90, now the 95 actually targets to improve retention as well as viral load suppression. And then also to improve access to medicines and patient experience. Next slide. So what you're looking at now is actually a detailed Cdu process on how we actually identify patients who are actually stable in the facilities. And once we identify these patients, there's what we call a prescription process where we prescribe for them, and these prescriptions are actually electronically transmitted to the central dispensing unit. At the central dispensing unit, this is where data capturing is done and parcel batching is so the CDU actually packs for these patients, and patient parcels are actually dispatched to different pickup points within town, different places where patients actually prefer to pick up their drugs. Patients on a specific date are then able to collect their drugs from the pickup points. And then, because this is an automated process, immediately a patient actually picks up their drugs from a pickup point within town. There's an automated feedback back to the CDU that confirms that actually this patient has actually picked up their parcels from their pickup point. And then that feedback is given back to the facility to confirm a patient is still active in taking their drugs and actively on the ART treatment. So next slide, please. So in terms of where the medicine distribution and dispensing is actually done, we have actually 23 popular pickup points spread around within the district of Ndola. We have 7 private pharmacies within the town center of the district where actually patients are able to pick up their parcels. These are actually popular because it allows patients to pick up their parcels after hours as well as the weekends when actually our facilities are closed. Then we have 7 government facility pickup points, which are located on the outskirts of the town, and patients who live around those places are able to pick up their medicines from these places. Additionally, we have patients actually who live around the facilities, and because they don't want to queue up, we pack for them and they just walk into that facility, demand for their medicines, and there's already a parcel pre-packed for them, and it allows them to actually pick up their medicines and walk away from the facilities without having to queue up. So in terms of processing for these patients, as of now, as of September 2020, we have actually done about, we've actually hit 15,000 patients whose prescription has been processed. And in terms of repeat dispenses for these patients, we've done 151 dispenses for the patients. Next slide. So it's interesting, this has been a very big question, is we are actually giving patients drugs away from the facility. How do we actually ensure that these patients are taking their drugs and they're doing well? So one of the monitoring indicator that we are doing is to monitor their viral load suppression for all patients that are actually picking drugs using our facility. So this is a breakdown of the suppression for a patient, where 51% are actually below the 21 copies per mil. We have 37 that are actually 37% that are undetectable. And then we have a range of 1% to 5 to 6% that are between 51 and below 1,000. So actually we've been able to maintain a good suppression rate for these patients, which is a very good for us. It shows that these are patients who are actually taking their drugs despite them being away from the facility for an extended period of time. Next slide, please. Of course, this program has come with its own challenges. We know that within the facilities, there's the 6 MMD, which is being implemented by another partner. But then what we've done is we've made them complementary, where we're actually even pre-packing for the 6 MMD, which is working so well because patients do not queue up. They just walk to the facility as well as pick up their parcel without queuing up, and they don't have to stay for a long time in the facility. One of the challenges that this model actually faces was the stigma. We have a lot of people going to different pickup points and they're picking up their HIV medication. So the biggest worry was the stigma. And yes, the need, one of the things we thought about is to include actually other medicines for other morbidities to ensure that people are actually not just picking the ARVs, but they are also picking treatment for other conditions as well. The other challenge is unavailability of other ART regimens or combinations, especially the second line and other types. So most of our focus has really been the first line. Those who are on first line and are actually doing well. So to try and mitigate these challenges, what we've done is we've brought every stakeholder on board, the MOH, we've brought in other implementing partners within the district to try and, deal with these challenges that we're facing. And this has been very helpful because we've got support from everyone, all players on the ground. The CDU has actually come with its own benefits. And most convenient is patients can pick up their drugs at a convenient place, even at a convenient time, which has been very good. The process is efficient. They walk in 2 or 3 minutes, they pick their medicines and they walk away. They can do it after hours or even over the weekend. Dispensing accuracy, because electronic, we're able to monitor every step at every point. So there's accuracy in terms of who has picked drugs at what point and when they're due to come back. And then their medicines is personalized, it's labeled for a specific patient, and that patient only picks up their medicines without asking too many questions. In the pickup points, we've ensured that they're actually professional pharmaceutical care who are actually attending to these patients, and if they need to attend to any queries or actually any questions, they are available to give pharmaceutical care there and then at that point when the patient is actually collecting medicines. Other benefits have been improved inventory, and this is a scalable and economical actually model which we can do under $2 per actually prescription of each patient. But most importantly is the decongestion that we've seen, and the patient adherence monitoring has been good. With our call center, there's a one-on-one interaction where patients are able to call our call center at any given time. And then the impact of the CDU, of course, has been the decongestion, reduced workload for our facilities, reduced waiting time for the patients in the facilities, more storage space, clinical assessments. Now it's mandatory for them to qualify to be on this program. They have to do their clinical assessment. Therefore, charts are updated and laboratory tests are done. This slide, I'll go through it quick because it just—
Tandaway, I apologize for interrupting. I just want to let you know that you have 1 minute left.
Thank you very much. So this slide, I'm ending soon. This slide really shows you how much impact the CDU has done then in terms of reduction in the number of patients they see per day, as well as the time they take actually to see patients. So this shows the impact of the CDU and how well it has done. Why should we continue? We've continued enrolling more patients on the program with a very good retention rate, good viral load suppression. Patients want to be on this program, so there's actually an overwhelming demand for the program. The decongestion has been good, and even with the event of actually the COVID, there have been a reduced physical contacts between patients and facilities. So yeah, the CDU, next slide please. The CDU has changed a lot of many lives because this is a good innovation that has actually helped our patients. I think, Roland, that is my last slide. Thank you very much everyone for listening.
Thank you, Tandaway. That was excellent. So we're going to try and return now to Dr. Felix's presentation. So we'll cue the slides up, and then Dr. Felix, whenever you're ready, please do start.
Yes, good afternoon, good morning once more. Hello, can you hear me now?
We can, yes.
All right. So, as I said earlier on, the project, Integrated Child Health and Social Services Award, is a 5-year project being sponsored by USAID, and has been implemented by the Association for Reproductive and Family Health in partnership with a consortium of Project Hope and FHI 360. We are implementing across 10 local government areas in Lagos State, and we have an overarching goal of mitigating the impact of HIV and AIDS on children and their caregivers. We're also in partnership with the Ministry of Youth and Social Development, Lagos State, responsible for the coordination of all these activities. We have 4 broad objectives. The first one seeks to increase the access of caregivers to household economic strengthening to be able to meet the needs of their children sustainably. The second objective is to also strengthen the capacity of community to protect the rights and interests of the children through the Child Safeguarding and then the Child Rights Act implementation at subnational level. And the third objective seeks to strengthen the capacity of community-based organizations, local government and state governments to be able to coordinate and respond to the needs of vulnerable children at the national and subnational levels. While the fourth objective is addressing the issues on OVC subpopulation, and it seeks to increase their access to services. Of course, this population requires multi-layered services, and the group includes HIV exposed infants, children living with HIV, and children of persons living with HIV. All these require very peculiar approaches, and then we implement the DMOC, differentiated model of care, to make sure we address their peculiar needs as required. Next slide, please. So, as part of the background, the situation on ground, the HIV situation in Nigeria, and then the interventions are largely driven by USAID and donors. And not quite long ago, the USAID, in concert with other donors and government of Nigeria, conducted the National AIDS Impact Indicator Survey in 2018, which showed a marked reduction on HIV prevalence in Nigeria from 3.4 in 2012 to 1.4 in 2018. Of course, prevalence varies by states, and Lagos State as at then had a burden of 124,011 persons with HIV, with 47% not yet on ART, which also places them as amongst the 7 red states with high unmet needs. This is also worsened by the outset of COVID-19, which also happens to start from Lagos State, because the first COVID-19 patient was identified in February 27 in Lagos State, and since then it has continued to increase. Currently, Lagos State accounts for 33% of the total COVID-19 burden in Nigeria, and it's also a huge challenge. And during this period, there were a number of measures implemented, including the lockdown, which prevented people living with HIV access to their routine ART, refills, and other sundry drugs at the facility. So we, in implementing the ICSA project, innovatively came up with the mobile ART delivery model, which seeks to take the drugs at the doorsteps of the beneficiaries, particularly those that are due for refill between the months of April and May, to forestall a situation of increase on loss to follow-up cases, and so on. Next slide. So these are the strategies we adopted. First of all, in concert with treatment partners, we were able to generate lists of those that are due for drug refill during the COVID-19 period, with reference to their PEPFAR ID number and then the drug regimen that they are currently in use. We also engage them through the primary care providers at the facilities. As you can see on the top right picture, the pharmacist making some call to make sure that this person is willing and ready to receive the drugs at mutually agreed spots. So we had scheduled visits to the household, utilizing community points for drug delivery, especially the patent medicine vendors that are in the community, so that many people patronize the PMV for some other drugs, conventional drugs. And then it reduces stigma. As they go there to pick their ARV, nobody knows what they have gone to do. So they move in and pick their drugs and then leave quietly due to the stigma, and then confidentiality is maintained. In addition, before the outset of the program, we also trained the implementers of the project, the MAD team, and then in line with COVID-19 guidelines, provided them with PPE to ensure that they're equally protected, and then their clients are protected too. We, in concert with the government, obtained the pass identification mark that will enable them to move smoothly across the Lagos State without any harassment from law enforcement agencies then, because there was total lockdown in Lagos State, which restrained movement and restrained access to facilities. But with the pass we obtained from the Ministry of Health, we were able to move on to provide these services. You can see on the right, the store where the drugs are being sorted out according to the regimen required, and down the delivery, the picture below, to the clients. They tell us where to bring the drug, either at the PMV or at a secluded location where their privacy and confidentiality will be maintained. That we adhered and respected very strongly. Next slide. So in all, a total of 107 beneficiaries who through the line list we generated, we are due for uptake of services between April and May. We are reached with the ARV at their desired location, and then confidentiality was maintained. 37 CA children living with HIV received their drugs, and then 7 persons living with HIV also received their drugs while at home, and expressed immense gratitude to USAID for this unique intervention. Next slide. We also have, in terms of the number that are involved, 100, then for the duration, those that are benefited from the ART, we try to appraise their background and found out that 15% have been on ART for less than 1 year, while 13% were on it between 1 to 2 years, and 71.6% have been on ART for over 2 years. Of course, you imagine what would have happened if they had missed their drug for 2 months. There would have been increase in loss to follow-up. There have been a relapse and possible progression to the advanced level of AIDS, which could also be very, very devastating. So this unique intervention has been able to sustain them on their ART without any break in terms of drug uptake. And now for a number of them too received 3 months, while a few others received less than 6 months, depending on the need as required. So in all, we were able to serve a total of 107 that we are due for uptake of services. Next slide. So in conclusion—
Dr. Felix, we have 1 minute remaining. My apologies.
Yes, in conclusion, the mobile ART distribution is a differentiated model of care to forestall loss to follow-up cases and decentralized service delivery during emergency. It should be sustained as a coping mechanism to the COVID-19 new normal and economic challenges, strengthening transportation to facility for uptake of services due to the economic challenges. Please permit me to appreciate my other authors that also contributed to this, particularly Doreen Mogaji, the USAID Nigeria OVC Manager, Fetlana, Deputy Chief of Party, Hossein Idabo, Director of Program, John Ibitoye, Director, Strategic Information, Sontio Jimmy, the SI Manager, Oladipo, the President of CEO AF, then Fubara Adebonye, State Program Manager, and Dr. Ayokunle Bello. All these made very significant contributions to this success that we have recorded in Lagos State within the period of total lockdown of COVID-19. And it should be sustained and ensure that a number of others that are indigent receive their drugs while at home. Thank you for listening.
Thank you, Dr. Felix, and thank you to all our presenters for their wonderful presentations. Before I turn the mic over to Hannah to lead our Q&A and discuss our key takeaways, I kindly ask all participants to please complete the poll before the meeting ends, and I believe the instructions are in the chat box. So I will now turn it over to Hannah.
And thank you to all our panelists for those presentations. Those were all fascinating. So we just have time, I think, for a couple of questions. We had a few coming in the chat box, which I think have mostly been answered. But let me throw one of my own questions out. You know, since this is a panel that is both on MMD and DDD, I wanted to ask a little bit about the interaction. You know, our panelist from CEROV, Dr. Rashid, pointed out that many patients actually weren't comfortable managing their stock at home.
And I'm sure there's a lot of reasons for this that it would be great to dive into, perhaps something around bottle sizes, you know, extra stigma for KPs. But I wanted to ask the other panelists if your patients experience the same thing. Is there a reticence from patients to move towards 6-month MMD? And how do you think DDD might be able to fill the gap there? So let me throw that question over to Mike to begin with, if you have any thoughts on that.
So based on what we saw from our cluster randomized trial, it was clear to say patient did welcome the 6 MMD as well as the providers. So from that experience and from those findings, we don't anticipate to see patients not willing to get 6 MMD. What we saw was that it's important that we also engage these patients as key stakeholders in this whole process. So for example, these patients are coming to the facilities. We also need to conduct more demand creation services so that they should be aware of the DSD models that we are currently offering. At the same time, we also need to understand the role of the CSOs, who also do a lot of work in advocating for some of these DSDs. So from our experience, we don't see any problems with our clients not willing to join or to be enrolled in 6 MMD. Thanks.
All right, great. And Tandiwe, do you have thoughts on that question? How has this played out in Zambia?
Okay, can you get me now?
Yes, thanks.
Okay, so this is a question on, sorry, come again. I was just taking the...
Sure, sort of the interaction between MMD and DDD and client preferences. So, you know, are clients comfortable moving to 6 MMD? Are there clients for whom they won't be comfortable with 6 MMD and there should be other differentiated care options?
Yes, okay, yeah, interesting question, and it's been an interesting experience for us. So what we've seen in terms of patient preference, we have the working class, the people who are busy with businesses, or they, you know, they keep up, those who travel, they drive trucks, they move between countries and all that. They actually prefer to pick away from the facilities, from the different pickup points, while the people who live just around the facility will prefer to pick up drugs at the facility with the 6 MMD. So the preference has really been what that individual does in terms of work or businesses. So that's the preference we've done. The busy people would prefer to pick up from a private pharmacy where we drop the parcel for them, while those who are not so busy are happy to actually sit at the clinic and pick up their medicines from the clinic.
Okay, wonderful. And I'm seeing, unfortunately, we're running out of time, so I won't be able to ask questions to all the panelists, but I just want to wrap up with a couple of key takeaways. So, I mean, from my side, I think it's clear, well, probably everyone can see, you know, rapid scale up of both 6-month MMD and DDD has been crucial during the COVID pandemic and is appropriate for both adults and pediatric patients. I think a lot of times we don't see these models being used as much for pediatric patients, so it's great to see 2 presentations on that. And then I think the point on patient preferences has been made really clear, that we need multiple options and that there isn't a one-size-fits-all. And then let me just throw it back to Lauren to see if she has any additional takeaways she wants to add and to wrap us up.
Thank you, Hannah. Well, I agree with your summation of these key takeaways, that it's incredibly important to engage the patient in determining what is the best course of treatment for them. And also ensuring that we are really approaching this from a family-centered approach and aligning MMD pickups for children and their caregivers. And approaching this, you know, from that family standpoint, so we can ensure that we are providing the best care possible for families. And it was very interesting for me to hear the patient perspective and how they could potentially be hesitant to engage in some of these DSD models because of stigma. But I think we are probably going to be cut off soon. So I would just like to thank everyone for their participation. Thanks to our panelists for preparing these wonderful presentations. And thank you to everyone for joining. This was an excellent session, and we hope that you got a lot out of this.
Thank you.
Thank you, everybody.
Thank you.
Bye-bye. Thank you.
Bye.
Thank you, everyone.
Thank you. Bye-bye.
Bye-bye.